Well, good almost afternoon, everybody. I'm Tom Grady. I'm the Director of Advocacy and Public Affairs for the Brain Injury Alliance of New Jersey. I'm also the facilitator for this workshop. Thank you all for attending today, and Dr. Gupta, special thank you to you as well, not just for this presentation, but for the ones you've done in the past on this very important issue. Before we start, there's a few ground rules, I guess you can say, with regard to the discussion. If you could please enter your full name in the chat box. This is in effect your virtual sign-in sheet. If you're going to request CEUs, remember that you must attend this workshop in its entirety, complete the workshop evaluation, and if required by your discipline, complete a post-test. Thirdly, I'll be entering the link into your chat for your convenience. I also think this is available on our website. I also believe it's on an email that went out to you earlier today or maybe last night. And then Zoom will provide a report of how long each of you stayed on the workshop. CEUs cannot be given if attendance is not verified. Questions are very much encouraged. And please enter your question in the chat box. They will be addressed at the end of the presentation. So the name of this presentation is the Neurosurgical Management of Brain Aneurysms and Stroke. Our presenter is Dr. Gaurav Gupta, MD, FAANS. And Dr. Gupta currently serves as Director of Endovascular and Cerebrovascular Neurosurgery at Rutgers Robert Wood Johnson Medical School. He is also the Director of Rutgers Neurological Disorders and Pregnancy Program and the Director of the New Jersey Brain Aneurysm and AVM Program at Robert Wood Johnson University Hospital in New Brunswick, New Jersey. He is also an Associate Professor of Neurosurgery at Rutgers RWJ Medical School. Dr. Gupta did his general surgery training at Columbia Presbyterian Medical Hospital of Columbia University College of Physicians and Surgeons in New York City. He then completed his neurosurgery residency at Rutgers, New Jersey Medical School. He was appointed chief resident at the same institution. He then completed his fellowship in endovascular neurosurgery at the same institution as well. He is an academic neurosurgeon with many invited book chapters and scientific papers in national and international journals, both in basic neuroscience and in clinical neurosurgery. He is also the recipient of the prestigious American Heart Association, American Stroke Association Young Investigator of the Year Award for his work on transplantation of neural stem cells and neural progenitor cells in brain for stroke. And his research was awarded top 10 research advancements by American Heart Association, American Stroke Association in 2001. So to say the least, Dr. Gupta is very accomplished, and I would say just knows a little bit about this subject matter. So it's my pleasure to turn this over to Dr. Gupta. And Dr. Gupta, thank you, and it's all yours.
Tom, thank you so much for that kind introduction. Everybody in life has a passion. I have found mine, and it seems to be stroke and brain aneurysms. After completing my neurosurgery residency, I was thinking of fields that I would go into within the neurosurgical field, and I thought that this is something that really attracted me, and I have dedicated my life towards the disease, the condition, the patients. My disclosures are that I work at Robert Wood Johnson Hospital and the medical school. If I wasn't working here, I wouldn't be working so hard. But it's a huge healthcare system, and I'm so proud to be working here. When I think of the future and neurosurgical sciences, I think that even though this Time magazine article said, will the man become immortal? It's quite unlikely that we would have control of all the diseases, the chronic diseases, the burden of stroke. It's very unlikely. I think a large percentage of them will still exist. And surgery will actually be most likely a last resort. There will be really, really new devices that will take over. And the role of surgery would be really at the end, when the medical management has failed. Obviously, prevention of stroke and brain aneurysms and other conditions would be key to have our population live longer. And it's not a matter of only living longer. I think our goal is to have them living healthier. That's the point. All right, let's talk about stroke. Stroke is of two kinds. One is an ischemic stroke and one is a hemorrhagic stroke. And in the ischemic stroke, the blood vessels that are there, the pipes which take the blood from the heart to the brain, if there is an acute obstruction of it, that's an ischemic stroke. However, when the blood vessel actually bursts, that's a hemorrhagic stroke, as you can see on the right side. So we'll touch upon all those, both these areas in the next 45 minutes or so. By the way, that's a CAT scan of the brain. On the left, you see this would be the patient's eye, the right eye and the left eye. This image actually shows you the ischemic stroke. This is a chronic ischemic stroke that happened some time back. And then on the right side image is actually a hemorrhagic stroke. This is a CAT scan of the brain, and you see several areas, these white areas in the center showing the hemorrhagic stroke. So let's start with an ischemic stroke. This is a video which I really like and just brings the point.
When a patient suddenly experiences symptoms such as weakness or paralysis in an arm or leg, dizziness, slurred speech, or double vision, it could be the result of a stroke. But just what is an acute ischemic stroke, and how does it happen? Clots can form in the heart or in the arteries due to various causes. A clot formed elsewhere is called a thrombus, and it can break loose and begin traveling down the artery with blood flow. Now it is called an embolus. Sometimes the blood flow will lead it to the brain, where it can block one of the arteries that is supplying the brain with blood. When this occurs, it's called an acute ischemic stroke.
Now you see here, what happened was the brain is usually very, very good in terms of our blood vessels that are there. And in this case, when the blood clot physically occludes the blood vessels, no blood can travel distal to them. And in this, what also happens is that the other collateral circulations, I mean, I always say to the residents, the brain is pretty much like New York City. It has many bridges and tunnels. So just because one bridge or one tunnel got obstructed, that means one blood vessel in the brain got obstructed. That doesn't mean the brain should have a stroke each and every time. There should be other collateral pathways. And the major catastrophe that happens is when a certain blood vessel becomes blocked, where there are no other collateral blood vessels, so no other blood vessels supplying the same area, or there is a frank, the burden of that single vessel occlusion is so high that despite the collaterals being there, no significant benefit, no significant brain is left there to actually have a function. This is an example. This is actually a pathology specimen of what, when we look at patients who died and had a history of brain strokes, this is what we see on those pathological specimens, the area of the brain which shows the stroke. I mean, it is very, very important to understand the anatomical and functional areas of the brain. And depending upon what blood vessel supplies what area of the brain, you get symptoms on the basis of that. And as neurologists and neurosurgeons, we know each function that can be affected from the blood vessel that is occluded, right? What is the whole aim of stroke therapy? There are two areas mainly in the brain that we are worried about. So in the center of the core of the infarct, there is not much you can do. That's the area where there are no collaterals, nothing is going on, one shot, and that part of the brain may actually die. 2 million neurons a minute is what we quote usually die. Not much can be done of that. And all the trials and the therapies that are based on are in for this penumbra. Penumbra is the area outside the core where the brain cells are not totally dead, and we can actually have some potential for therapeutic rescue. This is another thing, the dead brain in the center and the penumbra that is there. Now, this is a picture of an angiogram. On the left is a non-subtracted image, and this is a patient who had a stroke. Now you can see that this is the left side internal carotid artery. There's nothing there. The middle cerebral artery is not there. The anterior cerebral artery is not there. And the main internal carotid artery is occluded. And it should have looked like this. For example, on the left side, you can see what a normal angiogram should have looked like. But for this poor patient, there's nothing, none of those branches are actually seen. And that's actually a stroke. This is seen from the side. This is a lateral view. That this is a skull bone. When you delete the skull bone, you see that there is no perfusion in the brain at all. It should have looked like this. The image on the left is what this is supposed to look like. However, it looks like this. So that's the time, in 1995, there was a trial, the NINTS trial, which actually saw the efficacy and safety of using intravenous TPA. And that really revolutionized the way we practice medicine. I call it Drano, to open up the channels in the brain. And that really, really revolutionized. I was in medical school that time. And when we had this report that this trial came in, the NINTS trial, we were very, very excited, because before that, you couldn't do anything for the stroke patients, right? Okay. Now, not all clots can be dissolved with IV TPA. That's in those times, during those times, there are many, many studies that if the clot burden is more than 8 millimeters, for example, in the middle cerebral artery, as in this case, TPA is not going to open that blood vessel. TPA, tissue plasminogen activator. Our center is also going to start using tenecteplase in the whole system. Actually, Robert Johnson Barnwell system, tenecteplase in short time. We're just finalizing the details. In such cases where we don't think the IV TPA is going to work, certainly mechanical thrombectomy, and you can see the clot that I pulled out in one of the patients that you see down there, that is indicated. Let's go into the neurosurgical management. This slide is from my colleague, Dr. Roy Chaudhary. I've learned a lot from him. That when I was in medical school in 1992, we just, as I said, had the intravenous TPA. And then the trials in the medical devices started coming. The PROACT trial with the intra-arterial TPA. My colleague, Dr. Keller, was actually with Robert Johnson, was part of that trial, and he did these patients with just putting microcatheter up in the brain and injecting TPA directly. And then after that, it just took off. In the last 20 years, what we've seen is that the generation 1 devices and the generation 2 devices, and then the generation 3 devices, and fast forward to 2021, it literally, I mean, all major academic centers do this, that we are able to go from the wrist blood vessel intra-arterial, go up all the way into the brain and just grab these devices. Now, this is a Stryker video. I don't get any financial incentive, neither am I a consultant for them, but I just wanted to, it's a very nice video which actually shows what is thrombectomy.
Using a balloon guide catheter and with the aid of a suitable guide wire, the microcatheter is advanced through the occlusion and positioned distal to the clot for accurate deployment. The guide wire is then removed, and with the aid of fluoroscopic imaging, the Trevo ProView retriever is carefully advanced up through the microcatheter. Trevo ProView is visible under fluoroscopy for accurate placement and observable stroke behavior.
And there are many other stent retrievers that are in the market. This just happens to be a good video I found, which was very instructive. So let's start.
Positioning and unsheathing Trevo allow time for maximum clot integration. With its vertical strut orientation and tailored radial strength, the Trevo ProView retriever is engineered specifically for efficient clot integration.
And the whole goal is to capture the whole goal is to capture as much of the clot with only either no distal thromboembolism or minimal thromboembolism. There are several different techniques that we use. This is a stent retriever. There are other called adapt technique, where we just take the suction catheter, and Penumbra is a company which makes them. So a lot of different companies, this field of neurosurgical management of stroke is just taken off.
Tubular stent retriever design and spiral cell aligned cell area and no cell overlap. Prior view
And then we just pull it out. So these are the really things that are there. Now that fast forwards us to different, this is an example of the clot I pulled out from a patient. The pictures that I actually showed you was the same patient's pictures, not that what it should have looked like. This is what it looked like. And imagine, look at the times on the top, within half hour of first image being there or less. We are able to completely reperfuse the brain. That is just unbelievable. We grade ourselves on the extent of the reperfusion that we do on the basis of the TICI scores, and any score of TICI 2B or TICI 3 is considered really good, and the patient really improves. Quickly, let's we're continuing just to give you that we're talking about ischemic stroke and the neurosurgical management of ischemic strokes. So I'll continue forward. The trials that then what really changed were since 2015. Before that, before 2015, for example, in 2013, there was the IMS trial, and all those just were not good trials in my mind. They took devices which were not even being used anymore. They were old devices. The complication rate was very high, and we didn't achieve much. I remember in my fellowship in 2007 and 8, stroke, the surgery for stroke was terrible. 6 hours we used to be there in the endovascular suite. Fast forward that to 2021, I just showed you a picture in 30 minutes less compared to 2007, 2008. So it's really every trial of these have shown that these are successful. The newer trials in the last 5 to 7 years can actually prolong that treatment that we can do in a select group of patients all the way up to 24 hours. As I said, not every patient is a candidate for that, but select group of patients, even beyond 6 hours up to 24 hours, if there is something we call a mismatch, we do a CT perfusion, we can actually absolutely have a benefit for that. Look at it, look at these numbers over here, that the patients who had an MRS score from endovascular therapy is almost 50% compared to medical therapy of 13.1%. That's really key. These trials have done. Here's another trial called the Diffuse 3 trial. Again, 6 hour to improving it beyond 6 hours all the way to 16 hours by perfusion imaging. Same thing here, multicentric study, and look at the results from this one as well, that the number of patients achieving an MRS is 45% compared to the medical arm, which gives you 17%, and the MRS of 5 or 6, the worst ones in the endovascular arms, is very less as compared to the medical arms. And symptomatic hemorrhage in the surgical arm is only very little, slightly more than what is in the medical arm. And you have just improved the quality, sorry about that, quality of the life. So between 2015 and 2021, we have trial after trial after trial. These are the 2 trials I was talking about in 2013, that they really did not show much benefit there, because I think of several reasons. We won't go into the details, but they were using old devices, and the trials should have been done appropriately. And in 2015, here's the line where all these newer trials, MR Clean, the ESCAPE trial, and the benefit, look at the benefits of the 60% versus 35.5% in the MRS score of 0 to 2. I mean, these have just revolutionized the way we do ischemic stroke. Let's just switch gears to hemorrhagic stroke. Now, hemorrhagic stroke may be your traumatic brain injury, which is really not a stroke, but it does come under intracerebral hemorrhages. So that is very different. A subdural hematoma or an epidural hematoma is very different from an intracerebral hematoma, and that qualifies for a hemorrhagic stroke. Now, quickly, I'm going to show the difference between the both. For example, here's a guy who came in with fell down, hit his head, and this gentleman had a a traumatic brain injury from a subdural hematoma, as you can see on the left side. And then when we do surgeries for these, this is the subdural hematoma, by the way, this hyperacute blood or acute blood that you see on the left side. And when you do surgeries for this, there is no medical management for these ones which can really take out that blood. Not yet. So it's such a large bleed, you have to do a maximally invasive surgery. It's the same incision that I made on the head from here to here, and then open the bone. This is the bone, skull bone coming off. By the way, I get asked these questions, how do you put it back? If we put it back, then these are the plates and screws we use. And this is the first thing that you see. This is a subdural hematoma right there, traumatic brain injury. And I'm so happy that New Jersey Brain Injury Alliance is really focused its activities on brain injury. And this is a prime example of a subdural hematoma. This is the brain. This is the amount of clot that you saw on the CAT scan. And here, that was compressing the brain. And after evacuation, looks pretty good. The brain is pretty angry. However, the patient's going to be okay. So do all brain surgeries for intracerebral hemorrhage require such a big craniotomy? No, the paradigm shift is to do from maximally invasive to a minimally invasive surgery. There was a trial which we participated on for intracerebral hemorrhage. Even though this was published in the journal Lancet, and we were a part of the trial and got our names put on that trial, but it was a very unique trial. Multiple previous trials had shown that intracerebral hemorrhage, for example, a deep basal ganglia hemorrhage, is not beneficial to do open craniotomy. And then this trial comes and talks about doing minimally invasive ways to take out these deep basal ganglia or deep thalamic hemorrhages. For example, look at this patient. He has a 63 cc's intracerebral hemorrhage. And we were, as I said, we recruited this patient into the trial because otherwise the medical management was do nothing. Maybe control the hypertension, control the seizures, and that's it. These people used to stay in the ICU, and some at other centers where they're not offering minimally invasive treatment for intracerebral hemorrhages. These patients stay in the ICU for a really long time. They get intubated, they get then tracheostomized, and then the clot swells, and then they herniate, and then in the middle of the night they call the neurosurgeon, say, can you do a hemicraniectomy? Or the family just says that no, this is it, we've done enough, and we don't want him to live like that. So this is such a huge burden of intracerebral hemorrhages, the hemorrhagic stroke. And after these newer treatments that have come, that stereotaxically with just a single burr hole, we're able to put this. So in this patient, stereotaxically, we calculated the x-axis, y-axis, z-axis. Mind you, you're not actually physically seeing the clot. You're all doing a computer-guided surgery here, and you have your scans on something we call the stealth guidance. And in that, you're navigating this external ventricular drain right smack into the clot. Here's the axial section, here's the sagittal section. You put it right smack into the center. And after a stability scan, you start giving them TPA into the EVD. And look at this, by day 1, it was 63 cc's. By day 3, it was 10 cc's. And this is the hallmark. So a lot of this is the trial that we published in the Lancet journal. And a lot of people were very, after this trial, said that, well, it didn't show much efficacy. Well, it did show efficacy. And the main point that we wanted to show here was that if the volume at the end of the treatment is less than 15 cc's, those are the patients who are actually going to benefit from this. It depends, it really depends upon the surgeon's experience, how the clot was. So not every patient is going to have less than 15 cc's. Thank God we were, I think, the top 3 recruiters in the world for this trial. And the key thing here is if you can get the clot down from, for example, I showed you from 63 cc's to 10 cc's, those are the people who are going to have a long-term benefit. And now there is this paper that recently came in last year, that there is now evidence that taking these clots out from deep basal ganglia, yes, the pictures look pretty, but is the patient doing well as well? So look at this. I mean, this is incredible that the percentage of patients having a really good outcome and long-term follow-up really speaks highly of these newer therapies that we do these intracerebral hemorrhages. Next, let's move on to another area of hemorrhagic stroke. We're speaking about ischemic stroke, hemorrhagic stroke. We're continue speaking about the hemorrhagic stroke is something called subarachnoid hemorrhage from ruptured brain aneurysm, another example of a hemorrhagic stroke. Let's take an example of a 43-year-old female who comes with past medical history of hypertension and smoking and says, this is the worst headache I've ever had. I have migraines, but this is the worst headache. And by the time 911 got to them, they had a seizure and they were intubated. And then they called us when they saw the CAT scan that, hey, we have a hemorrhagic stroke. And at that time, when you speak to the referring doctors, you actually in your mind thinking, well, what could be the possible cause? Is the patient's neurological condition stable or not? Are they intubated or not intubated? If the patient is not stable enough to transfer, we actually don't transfer them. And we take the medical history, what the blood thinners are on, aspirin, Plavix, Coumadin, which could have contributed to the hemorrhagic stroke. Mind you, I get this question asked a lot that, okay, I know this, one of my patients has a 2mm brain aneurysm. Can I put them on blood thinners? Look, a blood thinner is not going to cause the stroke to happen, the hemorrhagic stroke. However, if the stroke does happen because of other comorbidities, and if it just happens, then it is going to be slightly worse because the patient is on blood thinners. Before transferring, we also see if there is family. What did the patient want? Does the family even want to transfer? And there is adequate data that we have that higher volume hospitals for hemorrhagic strokes are actually, the patients should be transferred to them from low volume hospitals. What we do tell them when we're transferring them that please stabilize the patient, put them on adequate short-acting drugs for the transfer process. Propofol is a really good one. Control their blood pressures during the transfer. Cardine is a pretty good drug that we give, and keep them on anti-seizure medications during the transport process, and then have an IV access, because the first thing when they come over, we need to find out, why does the patient have bleeding in the brain? What is the hemorrhagic stroke due to? So we do a CT angiogram. Now, when we get these patients, the aneurysm, for example, if it has ruptured, the 50 to 60% aneurysm patients are going to die right there. The patients that you and me see are the ones which have stopped bleeding. And our goal, the whole goal of this treatment, is to prevent the aneurysmal rebleeding. If the patient continues to bleed, they're not going to survive. There is adequate literature that BP control is also very, very important. This class 2A evidence, I think there's much evidence coming that the risk of giving antihypertensives must be controlled. This is very important. Should you drop their blood pressure? A patient's been living for about 15, 20 years with their hypertension, and they live around 150s, 160s, 170s, maybe even higher. We don't actually want to drop their pressures too much. You can't give too much of the medication. For example, if you drop it to 90 systolic pressure, then they're going to have a ischemic stroke. And now you had a double problem, because you have to maintain the cerebral perfusion pressure. And when the patients arrive, the first thing that we do is, after confirming that everything is stable, we do a CT angiogram, and that CT angiogram shows us the aneurysms. So let's take a step back and see what aneurysms are. Pretty much they are bubbles that form on the blood vessels, any artery. There is localized weakness, and then just like this bubble on the tire of your car, you're going to have a bubble on the blood vessel. This is an example of the internal carotid artery. This is a 3D picture of an angiogram. You can see the blood vessel is pretty normal in the lower half, and then there is actually a pretty big aneurysm that is there. Aneurysms greater than 15 millimeters are large aneurysms, and greater than 2.5 centimeters, 25 millimeters, are giant aneurysms. And look at that. I mean, that's the main problem. 2% of the population has brain aneurysms. We see a lot of brain aneurysms at Rapoport Johnson, being such a large system. The key thing here is that will every aneurysm, remember I said 2% of the population has brain aneurysms, not everybody will rupture. Most aneurysms, up to 50 to 80%, will not rupture. I have a huge clinic full of patients where I see, okay, you have a 2 millimeter brain aneurysm. The rupture risk is 0.5% per year. We're not going to treat it. We come back next year. So a lot of these patients are living with brain aneurysms, and not everybody needs to be treated, right? Of the ones that are ruptured, that's really bad because it'll be fatal in about 40% of the cases. And of the ones who do survive, 60 to 70% will have permanent neurological deficit. I mean, headache is one of the commonest reasons to present to the ER, and 1 to 4 patients out of 100 will have a ruptured brain aneurysms, causing the hemorrhagic stroke. Brain aneurysms can be silent, and that's what we talked about. So it's a very bad disease. Now, what are the risk factors for this? The closest or the biggest risk factors for these are hypertension and smoking. Family history does play a role. Old rupture in the same patient, if he ruptured in the past, plays a big role. Some genetic disorders play a big role in that. But overall, hypertension and smoking are by far the biggest risk factors. So when do we say your family needs to be screened? There are no specific guidelines that are there right now that, okay, these are the 5 points, and if these 5 points are met, then family must be screened. No, but what we roughly follow is that if one patient has 2 aneurysms, or there are 2 or more family members would have a brain aneurysm in this family, then we screen them first degree relatives. And we suggest to do a MRA of the brain that is without contrast. Prevention, if a patient does have a brain aneurysms, is there data on what we can do to prevent subarachnoid hemorrhage? Other than hypertension control and smoking cessation, we really don't have any further anything to prevent a brain aneurysm from rupturing other than these 2 things. Symptomatic screening for general population is absolutely not indicated. So I absolutely don't want many people after this talk going to their primary care physician saying, oh my God, I have headaches, I need to get screened by MRA because Dr. Gupta said you may have a brain aneurysm. No, I'm not saying that. Most of the patients who have headaches do not need to be screened for brain aneurysms. We've already talked about there's a class 1 evidence for both tobacco and that. Now, how do we talk to each other as medical personnel? For example, there's a Glasgow Coma scale between medical professionals for talking about traumatic brain injury and what the patient's neurological exam is. Pretty much same thing. We have the Hunt and Hess grade, or the World Federation of Neurosurgical Societies grade that predicts the outcome. And that's how we talk to each other. And the worse the clinical grade or clinical presentation in terms of Hunt and Hess grade, the worse the outcome. Let's quickly take a step back into the surgical anatomy of what we're talking about. As we know, the main blood supply to the rest of the organs from the heart is through the arteries. And specifically for the brain, there is 2 carotid arteries in the front over here. And from the subclavian arteries, there are 2 vertebral arteries which go towards the back. So this is a cut section that you can see from your aortic arch. You can get your carotid artery going up, external and internal carotid artery, and going up all the way into the brain. That is deemed as anterior circulation. And from the posterior circulation for the back of the brain, it's the vertebral arteries, 2 vertebral arteries coming up and forming the basilar. So again, reminded of the analogy of Manhattan being different bridges and tunnels. That's your circle of Willis that you're going to see, that just because one gets blocked or burst, that doesn't mean the blood supply to the rest of the brain is going to stop. If the Lincoln Tunnel gets blocked, traffic can still continue to go through Holland Tunnel and other tunnels and bridges. This is an MRA that we do most commonly for patients who we are suspected of having a brain aneurysm right there. That's what it looks like. It correlates very, very well. No contrast needs to be given. Shifting gears to the ruptured aneurysms for subarachnoid, as I said, why is it called subarachnoid hemorrhage? Well, so take a cut section of the skull. This is your scalp, and then is your skull. and then are the coverings of the brain, the dura mater, the arachnoid matter, and the pia mater. Pia mater is right next to the brain. All the blood vessels that travel, they travel in the space below the arachnoid. So it is the subarachnoid space, and any hemorrhage from a brain aneurysm that occurs is going to be subarachnoid hemorrhage. Now, mind you, brain aneurysms is actually not the commonest cause of subarachnoid hemorrhage. Traumatic brain injury, somebody bumping their head or car accident, that is the commonest cause of subarachnoid hemorrhage. And in non-traumatic patients, that brain aneurysm is the commonest cause of subarachnoid hemorrhage. These are major blood vessels. At the bifurcation of these blood vessels as seen in this picture, you get brain aneurysms because of the forceful nature of each heartbeat that is there. This is an example of a brain aneurysm, for example, down here on a surgical patient I had in the past. Now, how do patients present? The hallmark is the worst headache of life. Patients who have migraines say, well, I know I have migraines for the last since I was a teenager, but this is very different. That is because the headache is probably from the irritation to the meninges or the actual blood vessel rupturing. That gives them the worst headache of life. Patients may have a sentinel headache. Up to 40% of the patients may have a sentinel headache. That means maybe a drop of blood leaked and then it stopped, and the body's own cascade of the coagulation cascade stopped that aneurysm from leaking, and that's a sentinel headache. But the important thing to know is that these patients will say this headache is very, very different from my usual migraines there. Many studies have shown the other presenting symptoms being headache and nausea and vomiting, loss of consciousness, nuchal rigidity. And these patients present to the ER. As I said, headache is one of the most common reasons for patients coming to the ER. And the most common diagnostic error is failure to obtain a plain simple head scan. I have several stories where the patient says they had a headache, they went to an ER and the head was not scanned. They said, oh, well, it's your sinuses, go home. And the headaches didn't get better. They kept on going worse. And then they went to another hospital, and that hospital did not do a CT scan of the brain to look for any brain bleed and said, well, it's your sinuses, you're already getting antibiotics, give it some time to act better. And then suddenly the patient is comatose. And then somebody scans their brain. It's a very simple test. Now, I would say, do it. This is what a CAT scan would show. Here, that's an axial view of the CAT scan. This is the skull bone on the outside. The gray is the brain. And, oh, sorry. And here you see, right here, this is a classical description of a subarachnoid hemorrhage. And when subarachnoid hemorrhage does occur, then you also have blood going and blocking your water system of the brain and giving rise to hydrocephalus. I mean, look at these ventricles. They were supposed to be very small. This is the water system of the brain, pretty similar to your water system in the shower tub. The water comes in, bathes your body, and then goes out through small holes. And in this case, the water is coming in, the CSF is indeed coming in, but it cannot go out through the small holes because your drains are being obstructed by the blood. So in this case, that's the other thing that can kill the patient. So immediately we have to do something called ventriculostomy. And immediately on arrival of the patient, even doing any more treatment, we actually have to put in a ventriculostomy tube by drilling a hole here and putting a tube through the brain all the way into the ventricles to relieve the pressure in the brain. So summarizing the initial how we manage them is that a high level of index suspicion is very important. If you think, boy, this something doesn't sound right. Is it that the patient's headache is because of a brain aneurysm or a bleed in the brain? Just get a CAT scan. The index of suspicion should exist in patients for acute onset of severe headaches. Then we do, after the CT scan, we have to find out where the bleeding came from. Then we do a CT angiogram. And after the CT angiogram, we do a diagnostic tubal angiogram. Look, MRIs is not an acute test if somebody does present with subarachnoid hemorrhage. It's mainly for outpatient studies for patients who've been having 2 out of 10, 3 out of 10 headaches. MRIs, definitely you can do, MRA you can do, but in acute setting is going to be your CAT scan and your CAT scan angiogram followed by a diagnostic digital subtraction angiography that we say. I'll talk about treatment of brain aneurysm in a little bit, but I do want to spend some time on vasospasm. When a patient does have ruptured brain aneurysm, and this is a picture that shows what happens in about 3 to 4 days, the blood that is already there across different areas of the brain, that's going to have it degrades, it degenerates, and all the metabolites of the blood now touch the blood vessels from the outside. Blood can only touch the blood vessels from the inside. If they do touch it from the outside, that causes severe irritation and the arteries go into spasm. This is really, really critical. It starts on day 4. It actually peaks at day 7 and comes down by day 14 and almost gone by day 21. And the havoc that is there that the brain goes through is really, really a lot. So initially you start with a hemorrhagic stroke, and when the vasospasm sets in, that converts into a ischemic stroke because the downstream blood vessels are not going to have blood supply to the rest of the brain. And in the past, we used to do those HHH therapies. We don't use those terms anymore. We do induce hypertension and keep them euvolemic. But the neurosurgical treatment is basically going to be balloon angioplasty. So what we do in these patients that are refractory to vasospasm medications, we endovascularly go from the wrist or the groin, we used to do that in the past, and put a small tube, go all the way up into the brain, take a balloon, and physically dilate those blood vessels, almost like stretching the tunica media of those blood vessels right here. In the first image, you can see this is the vasospasm, and the middle cerebral artery and the anterior cerebral artery have become very, very thin. And look, after the balloon angioplasty, it's really opened up very nicely. Similarly, same patient, basilar artery, very, very thin, and after balloon angioplasty, these are procedures which are very high-risk procedures, and we do them only as a last resort. We do give patients nimodipine. That's the only drug that has been shown to have any improvement in outcomes. We started when the patient arrives, and we continue it to day 21. After post-subarachnoid hemorrhage. As I talked about in the past, we used to do HHH therapy. We don't do it anymore, or we don't call that anymore. Certainly the hypertension part of it, induced hypertension up to 180 to 200, is a very nice way of keeping the blood pressure elevated to counteract the ischemic stroke. But hypervolemia and hemodilution, that has not shown to be much of a benefit here. Our goal is usually to maintain the cerebral perfusion pressure. How do we know that a patient in the ICU has actually vasospasm? Every single patient, we do the transcranial Dopplers every single day. It's pretty much like your police cop standing up there and shooting a laser radar gun at the vehicle. And the same way we use transcranial Dopplers, that we can find the speed of the blood that is traveling in these blood vessels, and by that we can figure out whether, if the speed is very high, that means the vessel might be very small, which means they're having vasospasm. So we say clinical vasospasm and radiological vasospasm. We never treat one single modality. We never treat the pictures only. It has to match the clinical deterioration, unless it's very severe, of course. And then we treat vasospasm. So this is very key. Hydrocephalus, we already touched upon briefly, where we have to, acute hydrocephalus is really, really bad. It happens on most of the patients who are bad grade. Can happen in some good grade patients. And roughly 33%-ish patients will have a chronic hydrocephalus, which they will need to be shunted. And VP shunt is the one, but acute hydrocephalus, that is mainly for, as I talked about, the hydrocephalus external ventricular drain really, really is the key. We talked briefly about the cerebrospinal fluids. This is summarizing that last part we talked about, that it is produced and then it is absorbed by these arachnoid granulations. And in cases of the hydrocephalus, because of the subarachnoid hemorrhage, your outflow is gone, and that's why we put these external ventricular drain. Let's talk about seizures a little bit. Up to 20% patients may have seizures. after subarachnoid hemorrhage, it is because of the physical irritation of the brain from the blood that occurs. Rarely it may be due to the aneurysm itself, the mass effect and the pulsations. However, it's mainly due to that blood and blood products irritating the brain. Certainly, aneurysms where there is a large blood clot itself, they have more incidence of seizures than only subarachnoid hemorrhage. We actually don't, if the patient has never had a seizure, we actually don't leave them on anticoagulants for a long time. We do it only in the immediate post-hemorrhagic period, but after the patient has done very well in a couple of days, we just stop them. But patients who do have seizures, either on presentation, then we keep them for a much longer time. Let's come back to the treatment options on day one when the patient does present. There is two options. Basically, you have to stop the blood from leaking out from the brain aneurysm that it might be, and oh, sorry. Access. I don't know what to do for that, so I'm just going to escape that. Boy, I guess, okay. Sorry, I don't know. I'm just going to restart my presentation. Can you please tell me, Tom, are you able to hear me? That message suddenly popped up. Are we good?
I can hear you.
Okay, sorry about that. I think I clicked that in mistake. So basically, the goal of the brain aneurysm treatment is to stop the blood from leaking again. And if it's an unruptured brain aneurysm, then from the brain aneurysm ever to burst, you need to close the door to the aneurysm so it doesn't burst. And the ways of doing it is either traditionally with microsurgical clipping, or the newest technique since the 1990s is the endovascular coil embolization. And I'll show you evidence of both. In open surgery, what we do is that, sorry, these are pictures. I have the patient's permission for these pictures. But what we do is that we actually keep every single neurosurgical procedure that is done, the patient's head is in this. We don't want it to move during the surgery. So we actually place them in something called pins, Mayfield clamp or pins, because even under the microscope, if the patient's own heart rate or breathing can, when you do surgeries under the microscope, the whole head can move a lot. So that's why every single patient is kept in pins. The technological advancements are really, really high, even before we make a skin incision. This is a true picture of a patient where the CT angiogram that I was telling you about, we do 3D reconstructions of that and get such an accurate model of that you see that how many degrees do I need to turn the patient? What is the extension we need during surgery? And we do this sort of a practice even before starting the surgery. So when you go there exactly, I mean, look at this CT angiogram that we reconstructed that I already planned. Where is the aneurysm? As you can see in the third picture, the aneurysm is right in the center. And what sort of an incision and where, what craniotomy is the frontal air sinuses are going to be in the way? What do we have to do for that? So your entry strategy and your exit strategy is so important, and you pre-plan all of these. Plus, you see the aneurysm, we have to do this surgery right here in the forehead, but does that mean we make an incision up in the forehead? Absolutely not. That's cosmetically very disfiguring. So most of them, we do it behind the hairline, and then we turn the flap forward just above the eyebrows, and then do the surgery, because it's so important that cosmetically it should look good, even though the patient may be very, very sick from the subarachnoid hemorrhage brain aneurysm, but cosmetically it should have an excellent cosmetic outcome. This is a patient immediately after surgery, even though they're intubated, but as you can see, the surgery was right here from the forehead or on one side of the face and the front over here, but the incision is behind. The hair clipping is absolutely behind. In this patient, you can see there's a bacitracin ointment on the incision. So we do minimal clipping for these patients. This is an example of what we do. As I said, when we put the patient on pins, how do we open the skull up? I encourage you, all medical professionals, to be in the OR, at least see some of the open craniotomies. It's very, very, very interesting surgery, I should say. We drill holes burr holes, and then we join together those burr holes to actually do the craniotomy. In this one, you're seeing that these are the burr holes that are there, that were there, and then we're joining these burr holes with this drill. We go to Home Depot and buy whichever drill is on sale, and then pick up that drill and do the surgeries from that. And then we take off the bone. And this is how every single neurosurgical procedure is done. The open cerebrovascular procedures, obviously not the endovascular coiling procedures, we'll talk about them, but the open. And this is how we already saw that this is the first view of the brain that you see. This image, every single time I look at it, it just humbles me. This is a sense of our existence. That's the frontal lobe you can see. That's the temporal lobe. So do we go through the normal brain to do surgeries? Most of the time, no. What we do is we part the natural corridors of the brain. For example, in this case is the Sylvian fissure. And if you want to see where I'm looking in the camera, if we have to do the surgery on the opposite side of my hand, we don't go through the hand. We just take the natural corridors, split those natural corridors of the brain, do the surgeries, and come out. And this is an aneurysm, for example, of the patient I was talking about. And here is the normal blood vessel. The interesting thing is that with any neurosurgical procedures for brain aneurysms, you have to keep the blood going into the rest of the brain. I mean, these are blood vessels. You can't stop them. And while that blood is going, while the heart is pumping, you do the treatment of these. And this is clipping treatment. As I said, this has been what we've been doing for about 100 years, maybe more, that you just put a clip at the neck of the aneurysm so that the bubble doesn't burst again. And if the blood is not going to go inside, it's not going to burst again. Here's an example of a terminal ICA aneurysms. Right here is the ugly appearance of these aneurysms that are there, and then with the aneurysm clips that you see are there. Same thing here, seen in the picture on the right, is after the clipping what it looks like. Here's another patient. Here's the aneurysm, and here's the clip, which actually occludes the aneurysm. This yellowish thing is the calcium that is deposited in this aneurysm. And this is after we come out. I mean, we do these surgeries under microscopes. And in this one, you see that now we've zoomed out, and we leave minimal footprints on the brain. We try not to take away any brain function by going through normal important areas of the brain. This was the picture that I was showing you. This is what we thought we would do. When we went in, we took care of that aneurysm. You can see on the center, the craniotomy, and these are post-operative pictures, right? So this is on the right side bottom is a post-operative picture. We actually exactly did what we planned to do here, go in and clip the aneurysm on this picture right here with the red clips here. You can see the aneurysm which was there before. Now it's not there. We've clipped the aneurysm, used 3 clips, and kept the rest of the circulation to the brain completely intact. If you don't, then they can have more hemorrhagic stroke. So here's again the picture that even though the surgery was behind the forehead, right over here above the eyebrows, there is no incision up into the front here. The incisions are behind the hairline. We just peel the forehead down here towards the face, towards the eyes, do the surgery, put it back, and it's really, really wonderful surgeries. I encourage you guys to come once in a while, spend some time with us in the operating room. It's very, very exciting. Let's change gear to the endovascular procedures. This is the newest of the procedures. Again, this is the video that is from another company. I don't get any royalties for this talk or any consultant fees, but I thought this is a very informative video of the process of coiling. So let's look at that. What we do in coiling. Now, open brain surgery is done from the outside of the blood vessels. Endovascular is from the inside. So what we do is that in the past, we used to go through, this is the aneurysm as you can see at the skull base. In the past, we used to go through the groin, and that's what this cartoon shows. But nowadays, 90% of my surgeries are through the wrist blood vessels. We just go up endovascularly here and bring your tubes and catheters, no incision on the forehead, just a very small, tiny incision in the groin or the wrist. And then we with the blood actually going through the normal blood vessels here, we actually put these metallic coils there, and these coils intertwine, and that's why this is the coiling procedure here that is there. On the right hand, you can see the coils that have been placed in a cartoon there. So the whole paradigm shift came same about the time in the 90s when I was in medical school, and papers were published. The eyesight trials were published later on, which really showed that coiling is the way to go. Not every aneurysm should be clipped. I remember these times I was in my residency, when these papers came out in 2002, neurosurgery residency, and the open vascular neurosurgeons were not happy that, oh my God, no, this technique, new technique, minimally invasive is not here to stay. It's a fad that is going on, and they didn't believe in it. Endovascular treatment is very exciting. However, it does have its own challenges because, for example, the aneurysm recanalization here, the aneurysm has come back because the coils get compacted, is a significant challenge that we face. This is an example of a superior cerebellar artery aneurysm that I coiled. And on the right side, you can see that the coils are here. But what can happen with these coils is that they can be compacted in a corner because of the pulsations of the blood. So all those things over time, the coils that we use, those bare platinum coils, they've changed their improvement in length, softness, detachment zones, all the way from the wrist all the way to the brain. We do use balloon assisted coiling. And there are numerous trials which say that for wide neck aneurysm, this is a wide neck aneurysms, where if you put the coils in them, the coils are not going to stay because it's a wide neck. The door is pretty big. So in those cases, you can put a temporary balloon over here and then compact these coils, and then the coils will stay. Here is an example. Here's a balloon right there. We compact those coils in there and then come out. For patients who are mostly for unruptured brain aneurysms, stenting is another option that we can't, for wide neck aneurysms, it's like a mesh-like device that you paste inside, and then you go through the tines of these stent, and then you deposit these coils over there. The problem with all these, not a problem, but one of the things you have to keep in mind is that stent is a foreign body. It's made of metal. So these patients need to be on dual antiplatelet agent, anywhere from, some centers do it for 2 months all the way to 1 year. And after that, baby aspirin for life. Here's the technological advancements are so good that the stents have different. Back in when I was training, Neuroform was the only stent we used to have. And now there is the newer generations of the same stent. We have changes in the stent design. Here's the industry has revolutionized the way we do this. I mean, the technological advancement. This is how a stent triever, by the way, is made. I just wanted to show you. They take a pipe which is made of metal, and this is a laser etching, and they are with laser guide. It's just taking off these cells. And you can see that's how it's just fascinating, the technological advancements that are there in making these stent retrievers and stents. Isn't that wonderful? And because of this, we have newer stents. Here's example of a patient, very wide neck aneurysm that was there. I put a stent, you can't see it, only the dots here, you can see stent from here to here, and then these coils inside, and the blood is traveling to the rest of the brain. Here's the newer stents, the Elvis stents are there. Here is an example of a patient who was ruptured brain aneurysm. Now, we do at higher centers who have experience doing these, we do stenting for acutely ruptured aneurysms. Here's the stent there. Here's the basilar tip aneurysm right there. And I've made the blood vessel transparent so you can actually see the stents that are there. Here's another example. This is the same patient of a transradial doing it. Here is how we do transradial. I mean, this is really revolutionized how we do endovascular. We come from the right arm. Here I'm going inside the heart, bumping my catheter off one of the valves, and then going up. In the past, 5 years ago, we weren't doing this. We were doing everything transfemoral. And here's another okay, and here this is the face of the patient. You're coming from the right radial artery going up there, and even contralateral carotid arteries, the catheters and the tubes have become such stable constructs that you can really do brain aneurysm treatment from the wrist, and really after the patients, they wake up, it's only a small pencil hole, and it's just amazing the technology that has come. Here's the surface area of different stents that we use today, anywhere from 8 to 10%, all the way up to 30-35%. The newest generation is called the flow diverters, because The challenges of large and giant aneurysms, what do? Your regular stents and regular coils are not going to work. So then the flow diversion came in, and the last couple of minutes I have, we'll just talk about flow diversions and flow diversions there. Tom, how much time do I have?
Dr. You have 15 minutes. I was just about to give you the 15-minute warning.
Okay, sure. Thank you. So we'll be done by 15. We'll have time for questions. So what about the large and giant aneurysms? So basically for this, since the pipe itself, now remember from the coiling and clipping, you're only treating the aneurysm, you're only treating the bubble, but nobody's talking about the vessel, the parent vessel or the parent pipe, which is damaged, right? So in flow diversion, what we do is that we treat the aneurysm, but we actually primarily treat the pipe which is damaged. So how we do it is in the next couple of videos, we'll show that how it's done. And the advantages are that the parent vessel is healed, and all the perforating blood vessels which are coming out of that area of the blood vessel that you treat, they remain open. In this case, here's an ophthalmic artery, for example, going to the eye. We're going to put a stent from here to here. It's a flow diverting stent, very high density. Mind you, it's not the same as the stents elsewhere in the body, not in the heart. This is a completely different ball game. The disease process is different. The heart stents are very, very different, small, less surface area stents. These are very, very high density stents. So here's a pipeline. This was, I remember, in 2012. This is the first FDA approved device that we had. It's almost like a Chinese slinky or a fancy pantyhose to actually reconstruct the parent vessel and indirectly treat the brain aneurysm. As you can see, that's Peter Kim Nelson, the inventor of the stent. He was the one who taught me how to do pipeline. And this really changed the management. Look at this carotid artery coming into the brain and a huge, huge aneurysms. In the past, I could only probably bypass these patients, extracranial, intracranial bypasses, pretty much like the heart guys, cardiothoracic surgeons do bypasses for atherosclerotic disease in the heart. But in this case, if the whole blood vessel is damaged, then we have to bypass these patients, connecting a conduit from here proximally to distally. But since the pipeline device or other flow diverters that came in, this is an endovascular bypass, no open brain surgery. From inside the blood vessel, you put a pipe inside a pipe. And here on this middle image, you can kind of see, it's not very clear on this, that the device has been placed, a fancy new pipe. And then 6 months later, you can see the beautiful reconstruction of these vessels. Here's another device that was same pipeline device. Here's the aneurysm in the center. I've made the blood vessels transparent. And here what you see is that there are two telescoping devices, one inside the other. You can see on the bottom one, the devices, telescoping devices, one inside the other. Here's a 3D reconstruction of that. Beautiful, beautiful. These are wires and meshes that intertwine, and each one of them can independently move as against the other. I'm told we're one of the largest volumes of patients we've done flow diversion from. I think probably around 550 or 600 cases I've personally done. And my colleagues here at Robert Johnson, Dr. Roy Chaudhary, very, very experienced. Haisoon is there, Imad is there. I mean, this is something that a comprehensive stroke center offers. Every major academic medical center should be able to do these complex procedures. See this multiple aneurysms that you see here, and 6 months later, it's completely healed, the endovascularly healed it. This is the trial that was there, the PUFS trial that was there, that really, really gave us the outcome data on how are we doing. We're definitely doing these trials to see if the outcomes are any better after this. And trial after trial demonstrated the complete radiological occlusion rates. Now we're talking about 90 to 95% range in 6-month angiogram. This is the Buenos Aires experience, pretty much similar to the experience here in the United States, that these really, really have a very good outcome. Here's the Budapest series, pretty much another large series showing that inoperable brain aneurysms now can be successfully treated endovascularly without the need of open brain surgery. I mean, this particular aneurysm in the basilar trunk is pretty much an inoperative aneurysm. Had it been with open brain surgery, we could really not doing anything. Look over here, it's compressing the pons, and there was nothing we could do about it before the advent of such flow diverting stents. And now you can see there is 90 to 95% occlusion. Here's the PUFS trial I was talking about. You take these nasty aneurysms right here, and endovascularly 6 months later, you really recreated the entire blood vessel. It's just blows my mind. We use these for ruptured brain aneurysms. We first coil the patient, and you can see the coils in this patient, and then we bring the patient back to heal the parent vessel. So this is another trial that shows for aneurysms which were either uncoilable or failed aneurysms, you can do that. What is the technology like? I like this video. Again, I don't get any financial incentive from any of the companies, my disclosures, nor am I a contractor for them, but I thought that the videos are very nice. So how we do it is that endovascularly, suppose this is the blood vessel which is damaged, and here you can see the aneurysm. So through the wrist we go, and we put a small tube up here, and through that tube, tiny tube, we put the device. We actually go beyond the aneurysm because we have to repair the blood vessel distal or further away from the aneurysm, start repairing it from there and come back. So now you see we start laying down this device, and it opens up, which was inside this tube over here, microcatheter, what we call it. Very small microcatheters, only a couple of millimeters. And here we've laid down this pipeline device in this case, and this over time, the endothelium that is there, which means the cells on the inner side will start growing, and then the cells will grow onto every single tines of this device, or these devices, not only this one, all of these devices, all the stents, and we have to keep them on aspirin and Plavix, 2 blood thinners, until all the tines, all the wires of this device, these devices are covered with the endothelium, and that scar tissue forms. And the device itself just slows down the flow of blood into the aneurysm, but the ultimate healing of the aneurysm is done by the scar formation on the entire device. And we just have to keep them on dual antiplatelet agents. See, for example, in this patient, very large aneurysm 6 months later. So really revolutionized. We already saw these pictures. This is just duplicate. Let's go after this pipeline device. Let's go into another device that came in, is that the Surpass device. And this is the newest of the devices that are there for flow diversion. I mean, look at the flexibility of these devices as compared to devices elsewhere in the body. The stents that we do in the brain is very tortuous. It's not straight. It's not like you go into the heart and straight blood vessel, or maybe only slightly tortuous. In the brain, it's very tortuous. So all these wires that have been there, it's an intricate system. They have to move independent of each other because they have to hug the inside of your own brain's blood vessel. So here's the Surpass device. That's AJ Wakalu. He taught me how to do the Surpass devices. He's the inventor of this. And again, we are told that we are the highest volume, either #1 in the country or #2 in the country for brain aneurysms with this device there. So this is the Surpass device.
Good for down to 5 minutes. Sorry to interrupt you. I apologize about that. Down to 5 minutes.
5 minutes, we'll be done by then.
Okay.
And see these inoperable brain aneurysms right there, which caused the hemorrhagic stroke. And 6 months later, that you see this beautiful reconstruction. So these are my last slides. There. I just want to put a plug into our newest system. This is one of my newest passions, is the neurological disorders in pregnancy. This is for patients, pregnant women. It's a special program that we have who suffer from ischemic stroke or hemorrhagic stroke. So we put together a group of physicians from every single specialty, and said, we come to one table and figure out how this should be done, because there was no program in the entire country which was dedicated. So we started a program. My book is coming out on these, where we talk about the ischemic stroke pregnancy and ischemic stroke pregnancy and hemorrhagic stroke pregnancy and dural venous sinuses. So, we try to answer the questions, the unmet needs in the stroke world. We have a New Jersey brain aneurysm program. Tom has been very kind that he attends those support group programs. We meet with our patients. Our nurses run this program. Myself, Dr. Roy Chaudhary, and other physicians absolutely come there. And for example, the one we had a week ago on Wednesday, we had a speech therapist come and teach us that what is speech. And when the stroke patients or hemorrhagic patients have speech deficits, how can we actually, what can be done for them? Here's the brain aneurysm support group, another one that I give lectures. Our patients are, we pride in that they are the most educated patients that we have. We also teach the other modalities, not only the Western system of medicine, but this is meditation and how we can use meditation to bring this. So with that being said, that is my last slide. Please feel free to reach out to me if any questions. More than happy to take on any questions that there may be.
Thank you very much, Dr. Gupta. Very, very informative. Appreciate that information as usual. Question for you. Is it possible for a person with a very small aneurysm to have it go away at some point? Is it possible aneurysm can disappear on its own without any intervention?
I'm going to answer that question with a question. If there's a bubble on the tire of your car or a bubble on the garden hose, can it go away? So the answer is no. Small aneurysms, 1 to 2 millimeters, when I get and the patient says, well, it was there and I don't see it now, that is probably because the radiologist who was reading it, it was so small on the MRAs. You can, if you're not really good at reading those studies, you can make anything look like an aneurysm, honestly. So smaller aneurysms, yes, you can mistake them, but they usually don't go away. Once the damage is done, it's done. They don't go away. No.
Interesting. And
they may remain stable. Most of the patients, most of the aneurysms are going to remain stable. How do we know which aneurysm to treat and which one not to treat? Is we calculate their annual rupture risk. And if the risk of the surgery is higher than the risk of the aneurysm rupturing itself, we don't do the surgery. Only if the benefits completely outweigh the risks of the surgery, that equation, we do it for every single patient, and only do the surgery when the benefits outweigh the risks. No surgery is risk-free.
Understood. And then if a person's managing his or her blood pressure effectively, since the awareness of the aneurysm, what are the chances of that growing in the future? Any idea, any speculation? Yeah. Or
so very good point. And the question, let me understand it, saying, for example, if we say, hey, this patient has a 5 millimeter brain aneurysms, okay, there is no indication to treat right now, but control your risk factors, which means the hypertension and the smoking. And if the patient's done their part of not smoking anymore and controlling their hypertension, does the aneurysm still increase in size? And the answer is it can. Hypertension and smoking are the risk factors we know of in 2021. But the genetic makeup we can't change. So if the genetic makeup of that particular vessel is a diseased one, it's going to progress, even though you've taken hypertension or smoking in control. So it is going to definitely benefit the patient. Yes, we see that those aneurysms may not increase in size, but we do see some patients, despite doing everything right, they still rupture.
Great. Thank you, Dr. Gupta. And I don't see any more questions at the moment, just as the participants may see on the screen. There's the evaluation link that's repeated a couple times and some other notes. So I think we are done. Dr. Gupta, really appreciate your presentation. Once again, very informative as usual. Hold on one second. I think two questions did come in. Okay.
And
One
from
more
our
quick
colleagues, if
question.
they have any questions, please kindly, this is such a disease. We are all part of the same team, jointly fighting this disease, stroke. So please email me, call me. I'm more than happy to, even in the middle of the night, if you feel your loved one or family member really needs help, please, I'm awake anyways, might as well talk to people I love.
That's very much appreciated. On that very positive note, again, Dr. Gupta, thank you very much. I look forward to working with you again in the future. And again, presentation very informative. And have a good day, everybody. Thank you all for attending.